I have a bronchial implant. My name is Emily, and my teammates are Desiree, Marissa, and Mia. So imagine having to gasp for air every time you take a breath. That is what it feels like to have chronic obstructive pulmonary disease, or COPD. COPD is a combination of lung diseases like emphysema and bronchitis that causes airflow limitation. COPD causes narrowing of the airways and causes the bronchial tubes and alveoli to fill with mucus. This is seen on the left. Specifically, the lung's epithelial tissue secretes mucin proteins. If the mucin proteins do not unfold completely, the mucus gets thick and sticks to the epithelial cells. An image of mucin is seen on the right. This trapped mucus causes bacterial growth, which leads to inflammation. COPD affects more than 15 million Americans and causes 150,000 deaths each year. The total life expectancy loss for a person diagnosed with severe COPD is approximately 8 to 9 years. Having COPD is also very expensive between hospital bills and treatments. According to one study done in Sweden, the annual cost for very severe COPD patients is approximately 17,000 euros or 19,000 US dollars. Furthermore, there is no cure. However, there are treatments. For example, a lung transplant that can help to prolong these patients' lives. However, the average waiting time for a lung transplant can be up to 2 years. There's a need for an artificial bronchial implant that can help COPD patients live longer and more comfortably with their disease by allowing increased airflow to and from the lungs.
Our approach to this problem is a drug-eluting stent to be implemented into either the primary or secondary bronchial tubes during a minimally invasive bronchoscopy. The stent will mechanically open up the airway through stimulated expansion. The stent will also reduce the mucus buildup, overproduction of mucus, and inflammation during drug release. The enzyme lipase, which breaks down lipids and fatty acids, will be used to modify the cellular process of secretion or exocytosis of mucus from epithelial lung tissue and break down pre-existing plaques. The device must alleviate symptoms of COPD by targeting thickened mucus and inflammation while still allowing for gas exchange and immune system functions. Here's a breakdown of the surface components of our device. The outer casing of the device is made of a bioabsorbable poly-L-lactate, or PLLA. The biodegradability will allow the release of 2 drugs, mitomycin and lipase, to help avoid fibrotic encapsulation and target mucus respectively. Mechanically polished nitinol surrounded by PLLA will allow the implant to expand within the bronchi, securing it in place. Nitinol has been shown to be biocompatible and effective for airway stents and will be used to open the airway. Pores in the PLLA will allow for gas exchange and for cilia to penetrate and continue functioning properly in the removal of foreign particles from the lungs. The mitomycin is vital to prevent encapsulation through these pores. To promote minimal and strategic endothelial cell adhesion, our stent is coated in laminin on either end. This will help further stabilize the stent. The center is not coated, and this is where mitomycin is concentrated to allow for easier removal after 3 to 4 years.
Our implant is planned for use in patients with mild to severe COPD. We're targeting this population because patients with mild to severe cases make up the majority at 73%. Furthermore, patients with these severity levels are more likely to search for treatment options. One big benefit to our implant is that it eliminates the need for a patient to remember to take their medication. It will resist airway compression, relieve chest pain, improve airflow, and help decrease mucus buildup. In addition, it would be a safer alternative to a full lung transplant. For comparative purposes, we looked at airway stent statistics. Financially speaking, it was about a quarter or less the price of a single lung transplant. We also found that the survival rate for airway stents was rather high. In 1 year, the survival rate was around 92%, and in 5 years, it was about 70%. Our estimated price for our stent is about $250 to $600. Some risks include the sensitive location of the treatment, which could pose fatal in the event of failure, and it could also need replacement depending on the length of the long-term drug delivery system. It would require a lot of testing due to the invasive nature and have a much more difficult FDA pathway. But we still think that this product is worth exploring.
There are several existing treatments for COPD. Patients may be prescribed pharmaceuticals such as bronchodilators, inhaled corticosteroids, methylxanthines, and phosphodiesterase 4 inhibitors. These pharmaceuticals often target the symptoms of COPD, such as coughing and tightness in the chest, and not the root cause of the disease. Hence, patients have to remain on these drugs often for the rest of their lives. In addition to taking these pharmaceuticals, a patient may work with their pulmonologist to perform various breathing exercises, such as timed and diaphragmatic breathing. These exercises have been shown to partially increase the ease of respiration for a patient. However, they do not target the mucus that builds up in a COPD patient's lungs, as our device aims to do. Another competitor for our device is a lung transplant. While lung transplants have been shown to prolong the life of COPD patients as well as increase the quality of their life, they have numerous risks, such as a risk of infection and a risk of rejecting the organ. Additionally, the average patient waits 2 years for a lung transplant, and 500 people die every year on the transplant list waiting for a lung. We kept in mind the limitations of our competitors as we designed our device and hope to improve the life of COPD patients with it. Here are references. Thank you, and we look forward to answering your questions.